Amity University has been ranked among the top 3% universities globally by QS and Times Higher Education, the world's leading university ranking organizations. It has been ranked India's #1 not-for-profit private university for the past 7 years. Amity has also set a new standard of academic excellence in India by becoming Asia's only not-for-profit university to be awarded US Regional Accreditation as well as India's only university to be accredited by the UK's Quality Assurance Agency for Higher Education. The university is part of the not-for-profit Amity Education Group, established more than 2 decades ago by the Chauhan family. Today, the group is home to over 175,000 brilliant students, pursuing over 400 programs in 60 diverse disciplines across 9 universities and 26 schools. Amity Group's vision of establishing a global knowledge network has led to establishing international campuses in London, Singapore, Dubai, New York, San Francisco, Amsterdam, Abu Dhabi, Sharjah, Tashkent, Mauritius, Nairobi and South Africa. Amity's strong focus on research and innovation has led to the filing of more than 1,200 patents, which according to the Controller General of Patents in India is the highest number of patents filed by any individual Indian university. Amity is also engaged in conducting more than 300 high-end government-funded as well as international research projects, including those funded by the Bill and Melinda Gates Foundation, United States Agency for International Development and the Leverhulme Trust UK. In the field of management, the university has developed more than 2,500 case studies in recent years that have been bought in 106 countries by over 2,300 leading institutions and organizations. The university has also pioneered the concept of industry-led institutions, where leading organizations such as the multinational conglomerate Tata, the UK's Royal Institution of Chartered Surveyors and the Confederation of Indian Industry CII have set up institutions in partnership with Amity on campus. Attracting some of the most brilliant students, Amity has instituted India's largest private scholarship programs, benefiting over 25,000 students. These students are blazing a trail of success, having filed over 100 patents and published 1,500 Scopus-indexed research papers. It has also awarded over 2,000 PhD fellowships to brilliant researchers to carry out path-breaking research in thrust areas that will impact the development of the country. The award-winning Innovation Incubator on campus has and attracted investments of over $40 million. The campus also has many high-end research centers, including ones set up with Nobel laureates.
Good evening, everyone. As per the vision of Honorable Founder President Sir and Honorable Chancellor Sir, Amity Directorate of Management and Allied Areas, ADMA, under the guidance of Professor Dr. Gurinder Singh, Honorable Group Vice Chancellor and Director General ADMA, and Professor Dr. Ramanjit Singh, Director ADMA, is organizing the ADMA webinar series. This is the 14th webinar of the series. On behalf of Amity University and ADMA, I, Dr. Pranay Verma, Professor of Marketing, welcome to the webinar our speaker, Professor Dr. Ranjani Krishnan, who is currently the Professor of Accounting at the LE Board Graduate School of Management, Michigan State University, Michigan, USA. I also welcome to the dais the Director of ADMA, Dr. Ramanjit Singh, to this event, who constantly encourages all of us. Also welcome to this event are the Associate Editor of all ADMA journals, Dr. Kirandeep Bedi, and the Editorial Assistant at ADMA, Ms. Soji Thomas. Today's discussion is on the topic, Impact of COVID-19 on Cost Behavior in Hospitals. COVID-19 and hospitals go hand in hand and has become an opportunity to milk from the patient for some hospitals. the cost perception for treatment of COVID-19 is definitely not very favorable. We expect to update our knowledge from today's session. Now I request Dr. Kirandeep Bedi to introduce the speaker to the attendees. Meanwhile, I would request the YouTube viewers to mention their name and email in the YouTube chat box.
Thank you, sir. Good day and a very warm welcome to all present here. We are really honored to have with us today Professor Dr. Ranjini Krishnan, who is currently Ernest W. and Robert W. Scharberg Endowed Chair in Accounting, the Ely Broad Graduate School of Management, Michigan State University, Michigan, USA. Professor Ranjini completed her MBA in 1993 and PhD in 1998 from the University of Pittsburgh, Pennsylvania, United States. She teaches management accounting and operations management to the MBA, executive MBA, and PhD programs. Professor Ranjini's research focuses on issues related to managerial accounting, cost behavior, and performance measurement. Her research also examines health cost, health quality, and health policy. Her research work has been published in dozens of top journals across the world, including Management Science, Contemporary Accounting Research, Academy of Management Journal, Management Accounting Research, Journal of Management Accounting Research, American Journal of Medical Quality, Decision Sciences, Journal of Accounting and Economics, Strategic Management Journal, The Accounting Review, and many others. She has 7,918 Google Scholar citations, H index of 40, and I-10 index of 105, which speaks about the quality of research work being done by her. She has given seminars in numerous universities and conferences in Australia, Austria, China, Germany, India, Israel, Netherlands, UK, US, and Singapore. She is the recipient of the 2015 Best Paper Award of the Academy of Management Annual Meeting, 2013 Best Paper Award of the Journal of Management Accounting Research, 2012 Management Accounting Section's Greatest Impact on Practice Award, the 2006 Notable Contribution to the Accounting Research Award from the American Accounting Association, the 2005 Notable Contribution to the Management Accounting Literature Award, and the 1999 McLaughlin Prize for Research in Accounting Ethics. She has won MSU's Beale Distinguished University Professor Award, 9 college and university level teaching awards, and was featured as one of the country's top 10 executive MBA professors in the Poets and Quants periodical. Dr. Ranjini was the editor of the Accounting Review for the period 2008 to 2011 and the editor-in-chief of the Journal of Management Accounting Research for the years 2012 to 2015. She is currently the editor of Accounting, Organizations and Society and Management Science since 2016. She is a member of various editorial boards, including Accounting Horizons, Behavioral Research in Accounting, Decision Sciences, Journal of Accounting, Auditing and Finance, Journal of Accounting and Economics, Journal of Accounting and Public Policy, Journal of Accounting Research, Journal of Economics and Management Strategy, Journal of Health Economics, Journal of General Internal Medicine, and Journal of Government and Non-Profit Accounting. Now may I request our Group Vice Chancellor, Amity University, and Director General ADMA, Professor Dr. Gurinder Singh Sir, who is also present here and has been a great motivating force for all us to invite Best International Fraternity to Amity to welcome Professor Dr. Ranjini Krishnan. Over to you, sir. Now, may I request Professor Dr. Ranjini Krishnan to share her views on the topic Impact of COVID-19 on Cost Behavior in Hospitals. Over to you, Professor Ranjini.
Thank you so much, Dr. Kirandeep Bedi. It's been a great pleasure for me to interact with the distinguished panel, and it's a wonderful pleasure to be here today to talk to all of you on this topic of COVID-19 in healthcare. I would really like to thank all the panelists. Dr. Ramanjit Singh particularly has been very patient in being in touch with me. I know that, sometimes I've not responded to his emails in a timely manner, but he has always been very gracious and very polite, and I really appreciate that he in this at this time when I know that it is a very tough time for your university like it is for mine, for him to be so gracious and in all the dealings. And Dr. Pranay Verma, it's been a pleasure since we met yesterday, and I really look forward to continued interactions with all of you. And thank you, Ms. Thomas, for your assistance. So I'm going to share my screen now, and I will start my PowerPoint. So as the topic mentions, my topic today is the impact of COVID-19 on cost behavior in hospitals. Interesting thing is that although we all know that COVID is kind of almost, I would say, disastrous on every dimension, not just human life, the economy, almost in every country across the world. Most industries like travel, entertainment, and so on have been very deeply affected to the extent that it's not even clear when they will be back on track, if at all. It has deeply disrupted education. In my lifetime of being in the educational sector for almost 30 years, I do not recall any other event or episode that has been so disruptive of the educational sector as COVID has been. And I think though that the largest, maybe one cannot rank it like this, but a huge disruption has occurred in healthcare. And actually this disruption is a little different from what people are thinking. Most people are, feel that hospitals are just overwhelmed right now with all the COVID patients, and maybe they do not understand that actually it's a little bit different from that. In the sense, what is going on is that there is a lot of capacity utilization of an unusual type, which is this infectious diseases and COVID. But at the same time, there's actually been almost a complete absence of other ailments like elective surgeries, or people just coming for other type of preventative care and checkups. So paradoxically, what has happened is for hospitals, on the one hand, they have had a huge increase in costs because of COVID-19 patients. And on the other hand, they've had a huge decrease in revenue because they're usually, kind of profitable activities are no longer, there is no longer demand for them. And one of the problems here is there is also a healthcare problem that is going to happen throughout the world in the last 6 months. The number of vaccinations, for example, of children has come down a lot. And so now the question is, after we are done with COVID-19 pandemic, is there going to be, are we going to get back to some of the old infectious diseases pandemics now? And so there are a lot of such issues. But what I would like to do today is I want to kind of systematically I would say unpack this whole issue of cost behavior in healthcare. I want to begin with the whole notion of what does cost mean in healthcare, and I want to then continue with how do we examine cost in a more refined manner, and then I want to then talk about specifically the effect of COVID on these type of cost functions that we had. So I think a good starting point here is to ask ourselves, what is the main cost goal in healthcare? Now, suppose you look at some other industry, like let's say the auto industry, like manufacturing a car, for example. Then the main cost goal for like Ford Motor Company is to figure out how much does a particular car, let's say the Ford Explorer, how much does it cost? If it is the Apple company, and let's say their iPhone 11, then the main cost goal is to figure out how much does it cost to produce that particular product like the iPhone. If it is a restaurant, and let's say that it is a particular lunch meal, which is, let's say, a buffet meal that is, that's 500 rupees, price is charged, then the question is, what is the cost for us to provide that meal? Healthcare is a little different. you cannot say what is the cost of X or Y, because the cost goal in healthcare is to determine the cost of care accurately over the entire treatment cycle. What this means is, let us say that a patient is admitted with a heart attack. So now you've got to run a lot of tests very quickly to figure out what is the scope of this heart attack, what are the options that are available, should the patient have surgery, if the surgery has to be done, does it have to be done immediately, what are the options with respect to surgery, is it going to be an open heart surgery, is it going to be laparoscopic surgery, is it going to be, are we going to put a stent, and so then after that the patient is now in the hospital for a few days when we have to monitor and provide additional treatment, and then the patient is discharged. Now let's say that suppose that this patient who had a heart attack also has high blood pressure and high cholesterol, and so they have these two problems. Now the goal of care is to make sure that the patient is fully okay, that they're healthy. But that also means that they'll have to make lifestyle changes. So for example, if they have high blood pressure or high cholesterol, they might have to change their food habits. They have to change their lifestyle, like, maybe go have some more exercise. That is really hard to monitor, right? I mean, like once you buy like let's say in the case of a car, you bring the car home, if you misuse the car, and because of that, the car breaks down, Ford is not going to say, sure, I'll give you a new car, right? It is your fault. You broke the car down. But in this case, let's say that the heart attack patient is discharged and goes home, but does not follow any instructions for the next 30 days. They don't take their medication. They don't make any lifestyle changes. And they come back to the hospital in 1 month or 2 months or even 1 year. The problem is in most countries, it is regarded the fault of the hospital that the patient has come back. Readmission is a very bad metric for the hospital. It is as though the hospital did not provide good quality care. But the problem really is perhaps the hospital did provide care, but the patient has not followed up. So why this is important for cost is that we cannot even determine when the care cycle ends. We can say that the patient is discharged from the hospital, but that's not where the cost accounting cycle ends. If our goal is that the hospital has treated this patient and the patient has gone home, there is other things that can happen later that will come back and increase the cost of the hospital after some time. So this never ends. It is almost like a continuing cost. So what are some of the things that determine how much these costs are going to continue, and what are some of the forces that are affecting healthcare costs that are generally different from what they used to be before? I'm going to first talk about some long-term trends that happened even before COVID started and that are going to continue, obviously. And then we will talk more about short-term as well. So some of the forces that are affecting healthcare costs are almost identical in literally every country. Most people think that healthcare is different in US, it's different in Germany, it's different in Bangladesh, it's different in India. That's not true. Some of these forces that are affecting healthcare costs are actually very similar in all countries. And first one, that is literally one of the biggest forces that's affecting healthcare costs throughout the world, is demographic changes, greater elderly population. And I will show you some data soon about how that affects healthcare costs in pretty much throughout the world. And so then when you have these demographic changes like greater elderly population, then you have to change the entire institution and the way it determines its cost function. You have to identify risks. You have to move some of these services to lower cost facilities, because hospitals are the most expensive facilities in the whole healthcare value chain. If you think of clinics or hospices or nursing homes and hospitals, hospitals are the most expensive. So how can we identify patients, make risk profiles, and know which risk profile patient to send to which part of the healthcare value chain, so that the total healthcare cost throughout the treatment of that individual is reduced? There is also a lot of technology that's coming up. One of the big healthcare costs, for example, is falls for the elderly. In most countries, almost half of healthcare costs are because older people fall and get hurt. And almost 1/3 of deaths in people over 70 throughout the world is caused by people falling down, either because of coordination problems or because of muscle weakness or just in general because of age-related things. So now there are some things that can help people to not fall, and also that can detect if somebody has fallen, so that health can very quickly, they can be taken care of, because that is in healthcare, one of a large cost driver is speed. So if somebody's gotten hurt, then how quickly can you attend to them literally determines totally how much cost is going to be spent on that patient. And then the complexity of the healthcare market. Entire world now has no boundaries. Think about COVID. 2 people in a market in China had COVID on December 3rd week. And today we are completely paralyzed as a world. 2 people in a corner of the world had COVID. And now we are between India and US, there are, I think, 20 million cases of COVID. So we cannot, like those days, right, 50 years ago, if somebody has tuberculosis, they're put in a tuberculosis hospital and the gates are shut and nobody gets to come in or go out. You can't do that. That is impossible now. So that makes healthcare very complicated. It puts a lot more challenges with respect to controlling healthcare costs. So now the first trend that I mentioned, greater elderly population. Here is a trend of elderly population in India. You can see the curve here is not even linear. It is exponential. So by 2050, for example, about 20%, more than 20% of the population of India is going to be over the age of 60, and almost 5% of India's population is going to be over the age of 80. This puts huge healthcare burden, because in pretty much all countries throughout the world, if an individual spends a certain amount of money in healthcare throughout their life, let's take an amount. Let us say from birth to the time you pass away, your total healthcare cost, let's say, is 10 lakhs. Okay, so let's just put a number there. Then pretty much in every country, about 60 to 80% of that 10 lakhs will be spent in the last 6 months of your life. So out of that 10 lakhs, literally 8 lakhs will be spent in the last 6 months of your life, and the remaining 2 lakhs is going to be spent. So let's say that somebody has a life expectancy of 85. Until they are 84 and a half, let's say, out of, if 10 lakhs was the total amount, 2 lakhs would have been spent, and then in the last 6 months, 8 lakhs would have been spent. So it is very expensive to treat an elderly population. And so this is the US dollar amounts for each age group. And this is literally identical to what it is in every other country. So you can see that 65 plus, the amount of healthcare costs are extremely high, much, much higher than it is at every other age group. There is also extreme inequality in spending that is very prevalent in India. And this has very big implications for healthcare cost functions. So if you notice here, this right graph here with the blues and the greens is the US. You can see that except for under 19, at every age group in the US, there is more expenditures on women, on females, than there is on males. And the reason for that is that, let's say at this age group from 19 to about 54, there are a lot of expenditures related to childbearing and so on and so forth, and men do not have those expenditures. After that, women tend to have some ailments which are more prevalent among women than men. And so because of that, there is more expenditures, as you can see. It is just not because women go to hospitals more frequently. Actually, it's opposite. They go less frequently. 55% of total admissions in a typical hospital are men, not women. But it is just that there is more that is going on. But in India, That's not the case. And this is LDCs, for example, that I put in the bottom chart. You can see that upper middle income LDCs, it's almost equal for men and women, the prevalence of healthcare costs. In India, there is extreme inequality, although in expenditures between male and female. Why this is hugely impactful for healthcare cost, which is the topic, my topic, is that very often women do not come to the hospital until something is getting it, until it's almost too late, I would say. So there is an infection, and it could have been let's say, bad effects could have been prevented if the woman was brought to the hospital or came to the hospital early. Now, unfortunately, by delaying, it becomes more complicated. That drives up costs. It also, of course, drives up bad healthcare outcomes for the woman, but it does drive up costs a lot. So let's say the first or second day of the infection, she could have come. Instead, they wait until like the 7th or 8th day. The costs are something like 6 to 8 times what it could have been if she had come on the first or second day. So this is something that is a public policy issue. It's a social justice type of issue, but it has impact on healthcare costs. Now let's talk about the role of physician leaders, because the general sense we have is that why aren't physicians doing more? Well, actually, to solve healthcare cost problem, everybody has a role. And what is the role specifically of physician leaders, for example? Their objective, if you're a physician, is to increase value delivered to patients. What is value? Value is healthcare outcome divided by the cost of delivering the outcome. So now, obviously, you don't have infinite resources. So if you really, if you can spend all the money and all the technology in the world, your health outcomes are going to be very good, but you have to trade off. You have to say, okay, this much cost I spend, this is the outcome. How will I make a decision as to whether this expenditure is justified or not? That is the whole concept of value in healthcare. And that is what we need to think about in terms of healthcare costs. How do we provide better outcomes at the same cost, or reduce the cost of achieving the same outcome? And improving value needs a fundamental shift in the way we think about both healthcare outcomes and healthcare costs. You don't increase value by just shifting costs from one group to another. So let's say you say, oh, I have this rich group of patients, let me extract a lot of price out of them, and then my poor patients, I will be able to make a profit on everybody now. That is not the way to improve healthcare value. Restricting services, saying that, oh, if you can't pay for these services, I'm going to be not providing you these services. That's not the way to provide value. Cutting administration or infrastructure, that is actually going to reduce value in the long term. So then the question is, the denominator here for value is cost. And you might say, what is a cost? As I said, here is where it gets very tricky in the healthcare setting. What is really a cost? Because there is not just, okay, what is the cost of providing this particular product, but it is, the cost can be a location. Like, for example, you could have a hospital that has one branch in Bangalore, one in Mysore, one in Dharwad, etc. And so the question is, what is the cost for a location? And each location may have different costs, but if you aggregate everything and put it as one, then you're not going to figure out how much it really costs. It could be a department like infectious diseases. It could be an ailment like COVID. It could be a specific patient, or it could be a payer, an insurance company, for example. Or in the case of a company, like a healthcare company, like a pharmaceutical company, you could have costs for a product line, a location, a customer type, a department, or a type of task. The point is that your cost accounting system should be able to give you an accurate amount of costs that are being spent, regardless of the level at which you're looking at costs. And so this level can vary with the level of aggregation. For example, you should be able to say what is the cost for the entire hospital. You should be able to say what is the cost for the infectious diseases department compared to other departments. within the infectious diseases, there is intensive care and regular care. What is the cost of intensive care? What is the cost of intensive care for treating a patient who has other complications, who doesn't have other complications? You can see that the designing a cost accounting system to get at what is the cost for treating an person in intensive care in the infectious diseases department who also has other complications. It's going to be very messy. It's going to have a lot of error in it, and you cannot afford to have that error. So let's look at some basic cost terminologies to see where the error comes, especially in the context of this infectious diseases like COVID. So any healthcare company like a hospital accumulates its cost, and then it divides its cost into two categories: direct costs and indirect costs. Direct costs are those that you can specifically say, I incurred this cost for this patient, like medicines or labor or masks or any kind of equipment you used only for this patient. And indirect costs are those that you use for a group of patients, for an entire department or for an entire building or for an entire facility. And the problem with this is that most of the costs in the healthcare setting are indirect. Because direct costs, at least you cannot, the error rate of making a mistake as to what it really costs is lower for direct costs than indirect costs. So as direct costs, you can directly trace, there are purchase requisitions and supply requisitions that every hospital keeps. And hospital technology, by the way, which in India is at the forefront of the world in terms of hospital technology, you can directly say that this medicine was used for this patient, and this patient was diagnosed with COVID yesterday, and this patient was diagnosed with COVID 3 days ago. You can tell. But these indirect costs, like let's say that there is a hospital ward and there are 2 COVID patients, and one is in room 1 and the other is in room 2, and both have COVID, and both were, let's say, admitted at the same time. And now what happens is you have physicians, you have a team of people who are taking care of both these patients, and both of them are both these patients are using the resources of this entire team. This is what is known as the indirect cost. You cannot tell that patient A had this much resources used and patient B had this much, because they're sharing these resources. You can't divide these resources easily and say A took so much, B took so much. And I will give you an example of COVID with respect to infants. Unfortunately, fortunately, not that many infants have had COVID, but there are some that have had, right? So you have a nursery in a hospital where there are 2 COVID infants that are there, and one COVID infant is doing better than the other, okay? So, but the same team is attending to both of them. So obviously they are going to be spending more intensive care on that infant that is not doing that well. But it's very hard to tell how intensive is it. So let's say as a physician, I'm spending half an hour on baby A, which is doing better, and baby B, which is not doing better, and I'm spending same half an hour. But that half an hour on the second baby, which is more ill, is very intense. After that, I can't keep on attending to many babies like that because I will get burnt out. So this is what we call intensity of cost. That is very hard to measure. That intensity is very hard to pin down and put an actual value to. So as I said, COVID, if the cost object is COVID-19 patient, then you have direct costs like surgeons and nurses and medical supplies, indirect costs like the entire ICU department, the recovery room, rent and insurance, etc. that you're paying, and other examples. The direct costs you can get based on the source documents. Indirect costs you cannot get from source documents. And so you have to use some kind of allocation mechanism, which can get very messy. So then the other 2 types of cost behavior that are really changing because of COVID are variable costs and fixed costs. Variable costs change in proportion to the total changes to the level of activity, but fixed costs remain unchanged regardless of the activity. And costs are variable or fixed only with respect to particular cost object in a particular time period. I know this is becoming a little technical, but we need to do this in order to understand the last part of this, which is the effect of COVID on the cost function. So variable costs change in proportion with output. If you have more patients, you have more costs. And fixed costs remain unchanged with respect to output. But the cost per unit variable costs are unchanged. So let's say that if I had to give a drip to a COVID patient, and so I have to put an IV drip now, and let's say the cost of providing that IV drip is 1,000 rupees, then per IV drip it is 1,000 rupees. That doesn't change. If I have 10 patients, I will spend 10,000 rupees on the IV drip. If I have 100 patients, I will spend 1 lakh on the IV drip. So that is what we mean by variable and fixed costs. So as I said, fixed costs remain unchanged over a very wide range of volume, but variable costs increase almost linear fashion with volume, like masks, medicines, etc. And now the problem COVID is creating is that it is shifting both fixed costs and variable costs in ways in which previously hospitals had never seen. And I will show you in a minute what I mean by this. This is a graph that hospitals use all the time to find out where are they breaking even. Below the break even, they make losses. Above the break even, they make profits. So if this is this graph here, the orange one is total revenue, and the green one is total cost, and the blue line is fixed cost, and this purple line is variable cost, then once, let's say 4,000 here is the break even. Beyond 4,000 is your profit range. So now if you have 7,000 patients, you will make a lot of profit. Under 4,000 is the loss range. So now it's important, and I will come back to this graph in a minute to show how COVID has shifted this graph really badly. Okay, so a last cost accounting issue I want to mention before I move to one other topic, which is the way the COVID has shifted the cost function, is this new frontiers in cost management that hospitals are employing right now, which is being very helpful for them during this infectious diseases COVID time. This is known as time-driven activity-based costing. The essence of this new technique of cost management or cost measurement is that everything in healthcare, in hospitals, the essence is time. Cost generally are very highly associated with time spent. And the problem is that we don't know how much time each person spent, and each person's time has different value. So this is a new technique that hospitals are using, where they say, okay, let us find out for every type of activity. Let's say COVID-19 treatment for children, COVID-19 treatment for young adults, COVID-19 treatment for senior citizens. For each of this group, what activities are we performing over the entire cycle of care for treatment of COVID? Who is performing this activity? How long does each activity take? Then we say, how much is the cost per unit of time for doing this activity? What other supplies, materials, drugs are consumed during this care cycle, and we will add all of it to get at a total cost. So here is an example. A patient arrives, a patient checks in with the receptionist, the office assistant, the green one here is the office assistant, reviews and records the patient's information. The patient sits in the waiting room, fills out the paperwork, waits for the appointment. In the exam room, the patient is assessed by the physician assistant. The patient might have to go for an X-ray. Then the surgeon comes, reviews the information before they see the patient, discuss the results with the patient, dictates the notes. There is a scribe who transcribes the notes. X-rays are taken. The patient is brought to this education room. They may watch some videos about their ailment, and then they discuss any surgical options, and then the patient checks out. So this is very popular right now in healthcare from a cost accounting perspective. What is going on here is each circle here is the time. So 2 minutes to check in and 5 minutes to review the information. This is the office assistant, the green. The gray is just the patient sitting, but the patient is sitting 25 minutes in the waiting room, 20 minutes waiting, 5 minutes to fill out paperwork. This doesn't mean there is no cost that is associated. Waiting room costs are there. There is rent, electricity, other supplies in the waiting room. those costs are being incurred by the patient for the 25 minutes that they're waiting there. Then the exam room costs are there. This brown one is a physician assistant. They are spending time. The surgeon is spending 25 minutes here, 10 plus 7 plus 8. X-ray room, there's an X-ray technician who's spending time. There is a registered nurse, which is this yellow, who's spending time. And then the office assistant again. So all these, the color key tells you what resource, labor resource is being used. The circles here are telling you the time spent with each of these resources. And this is known as process mapping. It is one of the most prevalent things in healthcare costing throughout the world right now, process mapping. And we accountants, for those of you, the audience who are accountants, we should feel pretty good because this whole technique of process mapping was put together by accountants. And it is now having an impact even in the treatment of ailments in hospitals. So it's very rare that accountants do something that is actually helping in treating the patient, but this is one technique where that has actually happened. So this is the process steps. These are the resources that are being used, and these are the time estimates. So, those, I just wanted to introduce you to some latest cost accounting techniques that have been very helpful now that we are in this pandemic. Now, let me just summarize a few things about COVID-19 and healthcare costs that is different from what we've already seen. Most of what we've seen already is unchanged for COVID, but some things have changed. And I'm going to now talk about, so far I talked about things that have not changed, and that whether it's COVID or heart attack, hospitals are still facing that problem. Now there's certain things that are a little different. Okay, so the most surprising thing for hospitals with COVID has been that they're seeing a reduction in elective services. So what we mean by elective services is, let's say that I had knee pain and my knees were worn out and I had to have knee replacement. Well, no, people are not coming for that anymore. Let's say I have asthma, so every month I have to go and have some kind of inhaler treatment. People are not coming for that. Okay, so let's say I have migraine headaches and I need to go every 3 months to get, some checkups. I'm not doing that. Let's say I have diabetes, so I have to have my sugar under control, and every 6 months I have to have a blood test for that. I'm not doing that. So there is a huge reduction in revenue generating elective services. In fact, very interestingly, they are saying that 2021 will be the year in this entire world when fewest number of babies are going to be born. So they say when you look at a 100-year cycle of human birth, 2021 is going to be like dip there. That is also kind of elective, so people are electing to not have children during a pandemic. And for hospitals, these were very regular revenue generating services. Let's take having babies, for example. By and large, 99% of the cases for hospitals, these were, I would say, straightforward cases. Women came, they had babies, they stayed for 3 or 4 days, and then they left. And most often the complications that used to come, hospitals knew what they were because it's a very old, for a long time, women have been coming to hospitals to have babies. And so they know the cost function, they know the treatment pattern, they know what type of women are high risk and high cost, what type of women are low risk and low cost. So throughout the world for hospitals, 30 to 40% of revenue was coming from women coming to have babies, because that is most women, if you think in their lifetime, there are only, unfortunately and fortunately, 2 times when they go to hospital. Fortunately, once is to have babies, and second time is, when they are seriously ill. And so as a result, that 30 to 40% of revenues was from having babies, and that was generally profitable for hospitals. That is going away. The second thing is that if you look at this monthly per facility revenue, you can see now that people thought hospitals are going to be swamped and full, and capacity utilization is going to be 5,000%. Capacity utilization is less than 10% right now. Other than infectious diseases, other than COVID, all other parts of the hospital wards are literally empty throughout the world. So the other thing is change in personal consumption expenditures. Dental services, it's usually profitable for hospitals. People are not coming for regular, dental exams, etc. Medical laboratories, people are not having regular checkups and cholesterol checks, etc. So, but prescription drugs is going up, obviously, because of the COVID problem. And capacity utilization has dropped sharply. Overall utilization has dropped by 30%. Non-pharmaceutical services like radiology, home healthcare dropped by 50%. And now in the last month, the August numbers, it's dropped even more. Okay. So at the same time, so they have had a drop in profitable services and a sharp increase in unprofitable services, which is COVID-19 treatment. So the cost of COVID-19 treatment, we all know, is extremely high and unfortunately completely unpredictable. So we all know these cases where a family of 4 will go for, all gets COVID and goes. The father who is 60 years old gets discharged in 2 days and is okay. The mother who's 55 years old spends 4 days, and their younger child who's 15 ends up spending 4 weeks including in intensive care. That is one family that I was reading about. Another family is the other way around. The youngest child who's 15 shows very minor symptoms, and the mother is now in a ventilator. So it is impossible to predict who is going to be really ill and who's going to be okay. So hospitals, as a result, let's say that 5 people come in. It is going to be impossible to say which one of the 5 will end up in a ventilator and which of the 5 is going to be completely okay in 2 days and discharged and goes home. So now you have to treat all 5 as if they're going to end up in a ventilator. That is astronomically expensive on the cost function. And hospitals are struggling with that. So let us take pneumonia. Pneumonia is regularly, let's say it's 20,000. But with COVID, you're now spending 90,000 and you don't even know whether you should be spending 90,000. So that is the problem. So when I mentioned this break-even point, let me show you now what happens. This is what is happening. Your total costs as a hospital system have gone up. Your fixed cost has gone up because you have to invest in all these new technologies, ventilators, new intensive care beds, new infrastructure, new ward itself, so that they are not getting other people infected. All these is driving up the fixed costs. And total revenues have actually come down because other than COVID, nobody's coming to the hospital. So massive losses hospitals are seeing throughout the world. And so some hospitals are probably making money by illegal means, by fleecing the patients and saying that unless you pay 5 lakhs, I will not treat you. But that is rare. And we don't usually, I'm just saying as scientists, we don't usually study fraudulent companies. Our base case is always companies that are trying to do their best, not fraud. So if you look at companies and hospitals and healthcare companies that are trying to do their best, right now the situation for them is kind of a little bit, critical, let's say. So what are some, finally, I'd like to wrap this up with some recommendations. What are some recommendations? Well, first of all, almost every country, the government will have to step in, because this level of cost for healthcare, the private sector cannot do on its own. We are talking about a cost which is even on a per citizen level, impossible for the free market or the private sector to bear. So governments will have to step in and provide subsidies for healthcare. Hospitals will have to reorganize. Until COVID came, the whole concept of having a completely separate infrastructure for infectious diseases was almost gone. Because when was the last time we had a huge infectious diseases outbreak? Very long ago. So most hospitals had maybe 10 or 15 intensive care beds for highly infectious diseases. Now we have to build separate buildings. Maybe we are back to the healthcare design we had in the 1950s and 40s, when you had tuberculosis hospitals and other hospitals for highly infectious plague hospitals. Maybe we are back to that, but that is huge cost constraint. So that also will have to be thought about. As I said, design of capacity planning for cost purposes. You'll have to think of separate infectious facilities. And lot of people will also have to change along. The healthcare system cannot rely only on itself to solve this problem. A lot of public health measures will have to be put in, like all that we are already doing: face masks, social distancing, event restrictions, vaccinations. I was recently reading that the whole concept of social events is probably going to change after this. I think that we are going to go towards a society where the whole concept of having 500 or 1,000 people attend a wedding or a birthday is going to be gone. I think that we are entering a phase of humankind, I would say, where things are going to be much more low-key because of this healthcare public risk that is posed to people. Like, one thing that happened in Michigan, for example, there was a wedding that took place with 30 guests, and we have a limit here of 40, not more than 40 guests can attend a wedding. And that, I mean, totally including bride and groom. And you have to have one entrance and temperature taken and the list of people, nobody over 65, nobody under 10, no pregnant women. And the family did all that, and they had 35 guests. Of the 35 guests, somebody had COVID. So because the incubation period is so high, they came, they didn't know, they spread it. Now something like 250 people have COVID and 10 people have already died from one tiny 35 people wedding. So I think as a human race, we have to go back and re-examine our priors. I think we are back to more or less a life where we say, let's curtail, some of these things, and let's think about public health first before a private celebration. And so I think that that's a complete cost accounting change in thinking because of cost accounting. And so that's some of the recommendations. And thank you very much. It's been great to discuss with all of you about this impact of COVID on healthcare. And I'm eager to see what questions you have.
Thanks, Dr. Ranjani, for a wonderful talk. A person like me who is not from finance, even I was able to understand everything about the cost factor and costing in the healthcare is concerned. Now, may I welcome Dr. Gurinder Singh, our Honorable Group Vice Chancellor and Director General ADMA, to speak a few words. Sir. He may be busy. He may be busy for some time. Dr. Verma, pass on to you for the questions.
Okay. Thank you, Dr. Ranjani. It was really wonderful listening to the impact of COVID on the cost and how the examples that you mentioned, where the mother is on ventilator, the son is on ventilator, and vice versa, all those stuff. Okay, so we have received very many questions. I would like to begin with a research question which has come in from Rivya Dias. She asks, I'm currently working on a thesis, the non-communicable disease burden and its economic impact on households in Goa. The non-communicable disease burden and its economic impact on households in Goa. COVID has actually postponed all treatment of such illness, but this has affected people to a great extent. Is it more because of the fear of the virus? What is your take on this, ma'am?
I think that That's a very good question, and good luck for your. I'm very happy that you're writing your thesis in this area. It's a very important area, and I think we need to understand this as well as we can. You're right that all types of diseases, communicable and non-communicable, have a very severe effect on household functioning, household finances, household just structuring and so on. And that already is, for a family that is constrained economically, it is really a very big burden. I think that, from communicable versus non-communicable diseases perspective, I think communicable diseases like COVID are worse burdens they are imposing right now for two reasons. One is that we don't understand it at all. And when we don't understand a disease, what happens is we tend to blame the victim, right? We say, oh, but this person went without a mask. Why did they order food from outside? Why did they not stay at home? So that is always the problem, right? If you think back, when we did not understand what was the reason for, let's say, leprosy, or tuberculosis, we always used to blame the victim. And we either blame them for their behavior, or if we are, let's say, I don't know how to put it, but if we have more limited exposure, we might blame it on, some bad luck or something, right? We don't usually say that it was out of control of this patient, right? That the reason they got this disease is not because of some mistake they did, or their luck, or their bad star, or their parents or grandparents did some sin in the previous generation. But it is nothing. It is random. It is completely random. They got it. You could have gotten it. SP Balasubramaniam, I was told, just passed away. I'm sure that he got good care and he took good care as well. Why would this happen? Right? There is no reason for these things to happen. I heard that in the Vatican, in Italy, I heard that several people who work for the Pope have gotten COVID. If you think about it, these people have dedicated their whole life in the service of God. Why would they have to get it, right? So this is a complete random event, and it poses. So the first thing we need to do is to remove the stigma that it is a pandemic, anyone can get it, you got it. Yes, if you have a party where you invite 500 people and you're recklessly running around in that party, denying that COVID is a problem, then yes, then you are a public health menace. You need to stop. But if you're taking precautions and yet you're getting it, then it is a complete random event. So for households, I think they need to first understand that this is a random event. It is a very, I would say, big event. You need to make sure that you attack it with everything you have, get good care. It can deplete the household finances very badly. But that's unfortunate. I mean, right now, as I said, unless we get subsidies or some help from governments, it's going to be very catastrophic for households. And so whether it's a communicable disease like COVID or a non-communicable disease like cancer or heart illnesses, the burden is similar, except that in a communicable disease, sometimes you blame the victim. That you shouldn't do. So that's my short take on that.
Thank you, ma'am, for your answer. And I hope Rivya Das benefits from this answer, and all the best for her thesis. We have got several questions, and all of them are complimenting for your presentation, and they're requesting for your PPTs. Meanwhile, I'll read out a question raised by Dr. Nixon Omoro. He first of all compliments you for such a good presentation on cost management in healthcare services. Then his question is, with the impact of COVID-19 on cost behavior in healthcare manifesting itself differently in different countries, given the level of preparedness and developed health system, how can we as business schools help come up with specific models or strategies to help in controlling high labor costs in our health facilities?
Thank you. This is again a very good question, and a pretty. I mean, I think it's it's a complex question. It will require, I think, more, it will require like a thesis rather than, a quick answer. Actually, COVID is affecting different countries very similarly. I know people look at mortality rates and say, oh, Italy had very high mortality. Some other country has low mortality. There is nothing like that. The only reason for difference in mortality is the demographics of the country. Italy, for example, has among the highest age group in terms of population. It has the oldest population among any of the countries in the world. Same thing is true for US versus India. Unfortunately, two of the largest epicenters right now for the virus. The average demographics of US is there are I think 3 times as many people over the age of 65 as there are under the age of 20 in the US. In India, it is completely reversed. There are 3 times more people under the age of 20 than over the age of 65. But I showed you how it is all changing even in India, of course. So the population pyramid is an inverted pyramid in the US with a lot more people older and a pyramid in India. So that is the only reason for the difference in mortality. There is no other reason why certain countries have differences in mortality. This disease takes its own shape. It has its own pattern. We can never tell who is going to get sicker, who is going to get okay. In terms of strategies, right now we are at a very preliminary stage. So all we are doing is when a patient comes in, we give everybody an intensive care, right? Because we don't know what's going to happen. As we learn more about the disease, we can make what is known as risk tranches. That's what hospitals do with other patients. So let's say I come back to the example I gave of a woman who's coming for delivery of a baby. Okay, what hospitals do is they put every time that there is a woman who's coming for a labor and delivery, they put them into 4 risk tranches. One is low risk, which is a woman who has no other complications, who is taking good prenatal care, who is everything is progressing as it should. Okay, and age group, everything for the woman is low risk. The second is kind of like what they say medium risk 2, which is a woman who has perhaps one other risk factor. Maybe she's a little bit older. Maybe she's the second baby and first baby, she had some unexpected complications and so on. Then there's higher risk. So this might be a woman who has some other complicating factor like diabetes or high blood pressure. But okay, still it's there. And the highest risk, these are women who have extreme complications. So they have preeclampsia or they have something that could make the labor go very badly for both them and the baby. Okay, so but it's possible to do that. It is possible to put these risk tranches for these women before they go into labor. And so so as a result, what is going on here is that we have to think about how to provide these risk tranches for these, like the question that we asked now, how do we provide these risk tranches? And so for COVID, we are not able to do that. We are putting everybody in level 4. And previously, until 2 months ago, we thought youth were okay. We thought people under 25, the complications are not bad. That's not the case now. We are finding that even there, the complications are high. So risk tranching, what we call risk tranching, is one of the biggest strategic things we need to do. We are not there yet, but we are getting data to do those. And that's the next step.
Okay. Thank you, ma'am. Risk tranching might be the solution. We have got a very interesting question from Dr. Mangava Lajuban Mukim. He asks, should the government make policies on these costs or will it be unknown to the public?
So I think that the government's role has to, like, one is to help hospitals and healthcare systems by providing some kind of subsidies. The other is all the encouraging people to take the vaccinations and so on. And third is making these treatments available, I think, in large quantities. And the public needs to, the worst thing the government can do is to deny that there is a problem, right? There are some countries where that is going on. And the second, I mean, some of the worst bad things the government can do is to deny that there is a COVID problem, to only talk about itself, like what a great job I am doing as a president or prime minister or whatever, premier, to manage. This is not the time to talk about yourself, okay? If you are a world leader, if you are a president or a prime minister or a premier of some country, this is not the time to draw attention to yourself as to what a great leader you are. If we are ever at a time in history when every political leader needs to think about their citizens rather than themselves, now is the time. It is not the time to worry about re-elections. It's not the time to worry about whether I'm popular or not and how many followers I have on Twitter. This is not the time. This is not the time to keep patting yourself on the back every day saying, look how well I'm doing. Look how low the death rate is. Look how wonderful I am. This is not the time. This is the time to say my citizens are struggling. Families are losing household members. Families are going deep into debt. Families are committing suicide. Families' entire lifetime savings is going to negative rates now. We are stopping education of our children to deal with this. Every citizenry in every part of the world is struggling. This is the time to rise to the challenge, to be the type of leader that you said you were, right? Well, whoever, whichever country, right? That so how can we do special? How can we come with government programs, right? Subsidies, pharmaceutical companies, lots of hospitals throughout the world are cost gouging. Now you get admitted with a 99-degree temperature. You're like, okay, unless you pay 1 lakh, I will not admit you into a room. This is not the time. How can you be so inhuman, right? How can you even think of making money out of people's sufferings? How can you think about your popularity rather than people's sufferings? This is what I don't know. I don't understand, but I'm a cost accountant. So my job is to talk about costs. And so now is the time for governments to rise up to the challenge, admit there is a problem, admit you don't understand the problem, because guess what? Nobody understands it. It's not you. Admit that the problem is severe. Admit that it is not going away for at least 2 years, and do everything you can to mobilize resources to help especially the most vulnerable people in every country to overcome this, whether it's direct subsidies or hospital-based subsidies or whatever you can do to reduce the healthcare burden for citizens. That's the #1 priority for every country.
Thank you, ma'am. I think we should all be more human during these times. I've got a very interesting question from Dr. Mavis Henricks. He asks, has there been a high increase in mental health services availed during the pandemic? Yes. And he further asks, has this trend been seen with private care practitioners as well?
Again, it's a fantastic question. And the magnitude of the mental health problem in most countries, as you know, is very severe. And unfortunately, mental health is extremely underfunded, and there is not enough capacity for it. So mental health is a very severe problem. In fact, you know, I think it's next to the pandemic, if I were to say, next to COVID, the biggest problem is mental health throughout the world. So there is not enough money, there is not enough understanding, there is too much stigma, like I said, attached to this. And it's very hard to diagnose, just like you don't know what will happen with COVID, you don't know what will happen when someone is depressed, for example. What are they going to do next? So mental health, from the early data we are seeing, mental health trends are bad, they're getting worse with COVID. Because if you think of social isolation now, you add social isolation to someone who's already suffering, you are going to, you know, it is, and somebody who's already depressed, economic impact of COVID on them. right? Because a lot of depression is also related to economic reasons, that you're poor, or you don't know how, you have uncertainty about economic, like what is going to be a future, that affects your mental health. So it's a very good question, and I think that again we have to think of more big picture policy solutions and tools for this, um, beginning with education, beginning with saying that again, if you're depressed, it's not because you're weak, or or you have kind of like you should be in charge or control. It is just like COVID. You got it, nobody can say why you did, but now let's find a solution. So it's a big picture policy question. It's a great question. So yeah.
Ma'am, I'll take one more question because of the time constraints. And this question has been asked by Dr. N. Sharadda. She asks, first of all, she compliments you. And then she asks, can we identify and group costs of various types, particularly in hospitals? Do you feel that activity-based costing approach will allow linking costs with health outcomes be meaningful?
Yes, absolutely. I think that's again a very good question. And I mentioned this time-driven activity-based costing, which is a refinement of regular activity-based costing. So one sentence, if I were to say for those people who are not accountants in this audience, the way to think about costs in your organization is not in terms of nouns. So if I say, what is the cost of manufacturing a car or treating a COVID patient? And if you say, oh, there is salaries cost, there is supplies, there is depreciation, there is taxes, there is rent. These are nouns. These are not things that you do to treat a patient. The way to think about cost is verbs. Use verbs, action items, right? We need to admit the patient. We need to test the patient. We need to treat the patient. We need to do certain, kind of medications, provide medications. All these are verbs: treat, admit, provide, counsel. So that's the way to think about costs, and activity-based costing exactly does that. Instead of taking these line items of cost from like a ledger, which are nouns, it asks, what is this cost being incurred for? What is this cost doing to treat this patient? What is the reason we are incurring this cost to treat this patient? So that is thinking of costs like verbs. And I think that's the best way you can get a full handle on costs, by thinking of them in terms of what they do, not in terms of what they are, but what they do.
Thank you, ma'am. We have received many compliments and also many questions, and they're asking for your PPTs, your email IDs. Okay. So, but because of time constraints, I won't be able to ask more questions. Now I'd request Dr. Ramanjit Singh, Director ADMA, to have his vote of thanks. Over to you, Dr. Ramanjit Singh.
First of all, Dr. Ranjani, thanks a lot. Thanks a lot for the wonderful presentation. And I must compliment you and appreciate you. You speak very softly, but very logically, and a pure marketing person who doesn't know ABC of finance and accounts. And I think Dr. Verma will also agree, because he's also a marketing guy. The way we were also able to understand, yes, what is costing. Now I'm thinking that in case my teachers at my time, they have taught me accounting and finance like this, then I may have taken finance as the specialization rather than marketing as the specialization, because you have been speaking very logically, very politely, and very softly. And the way you explained, thanks a lot. A wonderful presentation about the the impact of COVID-19 on cost behavior in hospitals. And this is the current topic, the main industry also, and that is your core area also. And wonderful. And we were getting appreciations like anything. I was handling all my phones, my Facebook account also side by side, because people were appreciating and asking, yes, for your presentation also, they want to see your presentation, because wonderful. The way you have shown everything on the slides, it's really remarkable, really remarkable. And we are on behalf of the whole Amity family across the globe, on behalf of our Honorable Founder President, Sir Dr. Ashok Chauhan, who is the main motivating force. who is always motivating all the Amityans across the globe, bring senior people, bring good people who can do something, who can give us knowledge, who can join hands with us also, so that we can work together. Our Honorable Chancellor, Sir, Dr. Atul Chauhan, who is the elder son, and he's a very young, dynamic Chancellor, who is always motivating all Amityans across the globe, because we are having so many campuses in India and so many campuses across the world. Yes, he's always saying, yes, let's do something. And our Honorable Group Vice Chancellor, Dr. Gurinder Singh, he was here, then maybe due to some technical issues, he is again not here. And we are thankful to him also, because he is a Honorable Group Vice Chancellor and our Honorable Director General also, ADMA, who is always motivating. He's always saying, Dr. Verma, Dr. Kirandeep, Dr. Ramanji, Dr. Soji, yes, invite good people, conduct some good FTPs, then let's have some good sessions. And all the Amityans across the globe, we are really thankful to you. Yes, the way you have explained all these things. And I thank all the audience also from across the globe, because I was just going through the audience list. Maximum audience, maximum attendees are from the other parts of the world, from the outside India only, and they are having different time zones, but they were sitting very patiently listening to you. And as far as various attendees are concerned, number of attendees are there on the YouTube also. And let me thank, very important is the IT team also, Dr. Sodi, who is heading the IT team, because without IT support, we can't conduct anything, especially in this lockdown period, in this time zone. Otherwise also, when we are in the campus, IT is always a big support. But during this time, everything can be conducted only with the IT support. Dr. Sodi and his team, Mr. Mobin, who is the IT host, who is helping us behind the scene, and the whole IT team. And we are thankful to you. And let me thank my own team also, because they are working day and night with me, because sometimes I am writing at a very odd time, around 11:30 in the night. Yes, this is a point what we have to discuss tomorrow morning, be prepared. And Dr. Verma, who is moderating the session, all the times the way he is moderating and handling the question answer session. Dr. Kirandeep Kaur, who is working with me day and night and helping me in the smooth conduct of the, as the webinars and the other events are concerned. Dr. Soji Thomas, who is always there. As and when I ask him, because the communication normally she handles this communication, the email communication and the other things, and she is helping us like anything. We are really thankful to you. And Dr. Ranjani, may I request you now, because this is online and this is being recorded also, yes, let's do something between Amity and as well as the Michigan State University, some joint collaboration, some joint research collaboration, where both the universities, no doubt, as compared to your university, which was established in 1855, our university is a very young university. Your university is almost a 200-year-old university. And we are not 200-year-old, we are maybe around 20-year-old as far as the university is concerned. Let's do something jointly where you can guide us, where you can guide all Amityans across the globe, your department, your other colleagues in the university. I will write to you after this webinar, and let's join hands and do something, some joint research collaborations where we can work.
Thank you. Thank you so much, Dr. Singh and Dr. Verma and Dr. Bedi. This is fantastic. And, you know, I think that there is so much that I feel I'm learning, I can learn from collaboration with you, because, you know, there is India and US are very similar. They're, you know, world's largest democracies, right? And I think that, you know, there is so, as a result from a thinking pattern and how people process information and how, you know, things are done, there's a lot of similarity. If you look at you know, Indians in the US, it's like the two countries are very similar. So I think that, you know, India is a younger country from an age group perspective. So there is some issues that arise that are different from here. And at the same time, India has also been dealing with more infectious diseases than any other, than the US has, right? There's every year there is, you know, there's, I mean, I remember once I had chikungunya, and then there's, you know, malaria. It's just a tropical, because of the tropical nature of the climate there. So I have heard that from just small sample, that some of the best infectious diseases people here, medical teams which are treating COVID, are of Indian origin. So they have brought a lot of people from, which is kind of, you know, from people who are of Indian origin, who have who have experience in treating infectious diseases that many people here may not have had. So, I think that as a result, there is a lot of synergies, that I think it's every collaboration is a two-way street. And both parties, I think, emerged from the collaboration, learning a lot and gaining valuable, I think, insights. So I think this is definitely, I would say that it's a great opportunity for me to learn from you, and I really look forward to this. And I know that right now the world, we are going through a lot of pain. It's not a great time, but I'm confident that it's people are resilient, right? Human beings are resilient, and in the end, I think we will emerge from this, and it'll be a better world. That is my hope. But in the meantime, I really look forward to collaborations and more,
Most we will be waiting.
discourse and more. Yeah.
Yes. As and when you come to India, please do visit our campus. It is only 1 hour drive from the airport, New Delhi airport. Please do visit our campus. And thanks a lot. Thank you, Dr.
Thank you so much. Yeah, thank you. Have a great evening. Take care. Thank you so much.
Thank you, ma'am.
Bye.
Wonderful listening to you.
Thank you. Thank you. You too. Bye. Bye.